Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Manet CHC for hosting today's session, Choosing Wisely, Tests and Imaging for Rheumatic Diseases with Dr. Gerson Bernhard. Gerson Bernhard, MD, is a clinical professor of medicine at University of California, San Francisco, UCSF. He retired from his own practice in 2007 after several decades in both community and academic practice of rheumatology in Wisconsin and Northern California. Since then, he has continued precepting rheumatology fellows at Stanford and UCSF and instructing medical students as well as general physicians, nurse practitioners, and physician assistants. And with that, Dr. Bernhard, it's all yours.
Good morning. Let's get started with one of the major vexing problems for clinicians in the primary care atmosphere. And I know that you're somewhat limited in terms of how much time you have per patient. I also know that a lot of your patients have limited medical literacy. And often I see consultations coming in on people who have multiple chronic disorders like obesity, hypertension, type 2 diabetes, arteriosclerosis, etc. So I'm picking and choosing what kind of testing you should do very much depends upon the clinical setting in which you find your patient. So to begin with, I'd like to point out to you that there are what I call 4 C's of rheumatic disease immunologic testing. And that is, they are complex. They're not easy. And the laboratories will vary as to their consistency. And very often, the laboratories will offer you a whole panoply of tests, more than you've really asked for, so to speak. And that in itself can be confusing. You don't know what to do with all of this data. They try to help you out, etc. But it really depends upon what the clinical atmosphere in which you're ordering the tests is of importance. As a result of this, a lot of the test results that you get back are confusing. And I don't blame you, because sometimes we find it confusing, even in the specialty. And you have to sort this out and relate it back again to the clinical situation. Very often, and I would say that primarily, these tests are confirmatory. There are a few instances in which they really are quite diagnostic, but for the most part, they are confirmatory to what you are seeing in that particular patient. And they can be confirmatory in a negative sense. They can be confirmatory in a positive sense. And they are costly. And I know that this is an issue for everybody, but certainly is true for safety net clinics such as yours. And therefore, we want to be very cognizant of it and pick them very carefully and therefore what I call wisely. So there are some survey immunologic tests that are helpful. There is rheumatoid factor, which is frequently done and recorded. And it's true in 60 to 70% of patients who have rheumatoid arthritis are positive, but it's also true in several other diseases. And I'll begin to show you that as we get along a little further. Probably the more specific test is the anticyclic citrullonated protein, so-called anti-CCP. This is positive in about 85% of patients with true clinical rheumatoid arthritis, and it's much more specific. And there are a few other situations in which it is positive, and sometimes it's even positive before the patient has much in the way of clinical symptoms or clinical findings. However, don't concern yourself about that. It's really not that kind of a survey test that you would do with anybody coming in to your clinic. until you have someone who presents with what we call inflammatory features of inflammatory polyarthritis. So if I had a choice of which of the two tests I would do, I would say I really am suspicious that the patient has rheumatoid arthritis, so therefore I want an anti-CCP. Rheumatoid factor also is of importance because there are some patients who are anti-CCP negative, but rheumatoid factor positive, and they have an inflammatory polyarthritis, which we call rheumatoid arthritis. This could be true, however, if they have some other closely associated inflammatory polyarthritis. I hope I'm not confusing you by I get a lot of referrals, positive patient with diffuse musculoskeletal symptoms of a variety of ages, and incidentally, they have a positive ANA. And it's true. 98% of patients with systemic lupus erythematosus have a positive ANA, but it's also positive in a lot of other diffuse connective tissue diseases, and even in a small percentage of the normal population. Granted, there is the issue of how high the titer is, and patients who have immunologically driven positive driven immunologically driven inflammatory rheumatic diseases have a higher titer than those who do not. But again, this is not a very specific test, and it can often mislead you. And we'll get into some of the evidence for that in a moment. If you are concerned that your patient may have something like a antiphospholipid antibody blood clotting syndrome, a simple screening survey test is the normal VDRL, which is easily available, lots of labs, not very expensive. And if you suspect your patient really has episodes of gout, then a serum uric acid is helpful, not necessarily diagnostic, but make sure that you know that the renal function is normal, because it's going to be elevated as a marker of chronic progressive renal disease. But these are simple, relatively inexpensive survey kind of tests. Now, why do people have positive ANAs? Well, look at this: drug-induced LE, a lot of other rheumatic diseases, including rheumatoid arthritis and all the other ones that are somewhat familiar to you. Certain viral infections will also give you at least a transient positive ANA. Chronic hepatitis, biliary cirrhosis, malignancies, mostly lymphomas, certain neurologic diseases like multiple sclerosis, which we now think is an autoimmune disorder, certainly autoimmune thyroiditis, and in the juvenile group who have a localized arthritis, so-called pauci-articular juvenile idiopathic arthritis, it will be positive. And people who have pulmonary fibrosis, and some people on contraceptives, and as I mentioned before, even in a normal population. So you see how non-specific it is. So it very much depends upon the titer, maybe to some degree, the immunofluorescent pattern that they may report from a laboratory. But more than that, realize that it is a survey type of test only. Here I can tell you that, we can order all of these other tests. Look at the panoply of stuff And there are a lot of laboratories who would offer you a large panel of tests. But are those panel of tests going to really direct you, or are they going to confuse you? So what I really would like to focus is, before you start ordering a bunch of tests, get a really careful musculoskeletal history. Does this patient have evidence of an inflammatory disease, or is it more in terms of a degenerative disease? How do you discern that? Well, most people who have inflammatory arthritis of almost any kind will tell you, if you ask them specifically, they'll tell you, oh, I hurt in the morning. It's stiff in my specific joints, not just all over, I ache and feel, but specifically, they can point to the joints that give them the greatest problem. And it may be bilateral symmetrical, it may be just a single joint or just a small group of joints. And it takes perhaps an hour or two to sort of limber up. They also might be able to tell you, if you ask specifically, do you hurt at night? Yes. Where do you hurt? And if they again can point to the same group of joints that hurt, that suggests to you that, yeah, there's some inflammation going on. And of course, the other markers of inflammation, skin lesions, eye inflammation, fevers, etc. You also want to know something about their lifestyle. What have they been doing? What makes things worse? What makes them better? But more than that, what is the degree or character of the impairment? What is it they no longer can do because of this? People with degenerative arthritis, particularly in a knee, will tell you, oh, I can't walk as far. I have trouble getting up out of a chair, or I have trouble with stairs because it hurts in my knee or it hurts in my hip, or my back gives me a great deal of trouble. People with inflammatory disease will tell you about other smaller functions, such as I no longer can tie my shoes as easily, button my shirt, work in the kitchen, etc., because it hurts, or I'm clumsy, or a combination of the above. But these historical things, in addition to your usual history, are important. I realize it takes a lot of time to weed these things out, but they're important because that's the sort of information that directs you toward what kind of testing you may want to order, given the fact that the tests very often are not specific, they're not diagnostic, they're helpful. So that's the kind of information you want to gather. And in terms of things like sleep, you want to ask them specifically, if you say, well, how do you sleep? They'll say, most patients will say, oh, I sleep well or pretty well. But you got to get to them more specifically. Do you wake up at night? Do you wake up in the morning feeling rested, or are you having trouble? On your physical examination, beyond the general examination, which we all do, you want to be more specific about the musculoskeletal exam. Do they really have evidence of inflammation in joints, i.e., are specific joints tender and swollen? They're not going to be grossly swollen necessarily. They may not be red and warm, but very often they are. And you want to sort of document which joints are involved. So if you got a patient who has a lot of joints, specific joints that are painful and stiff, and on your exam, these same joints are somewhat tender and maybe slightly swollen or slightly limited in motion, you have evidence for an inflammatory arthritis of some nature. Now proceed from there. I would also urge you to do good muscle testing. That can be very simple. What you're interested in is, sure, if a particular joint hurts, they're going to say, "Oh, I can't do this because it hurts." That's different from proximal muscle weakness in terms of getting out of the chair or when you test them manually. So going further, make sure you get some good basic tests, which almost all of us do. Blood count, creatinine, chemistries. We're going to want to know whether they're anemic. You want to know whether they got good renal function for two reasons. One, it can be diagnostic. Secondly, you're going to want to start some of these patients on medications, and you want to make sure that that it's going to be appropriate and safe. What I often see in referrals is the lack of a clean urinalysis. If you can get a good urinalysis, it's sort of a liquid biopsy, and it's awfully useful in terms of excluding or including certain diagnoses. Remember that the acute phase reacted sed-rate, CRP, platelet counts can give you a clue as to whether or not you're dealing with someone who has an diffuse inflammatory disease, or whether this is not, because you want to try to exclude people who have degenerative arthritis, people who have fibromyalgia, from those who have an inflammatory, immunologically driven rheumatic disease.
We have a couple quick questions, Dr. Bernhard.
Yeah.
One of them is, and I'm not sure if I'm saying the word right, what titer of ANA should refer and what titer to do additional labs?
When do I assume this means, when do you get an ANA? If you have a patient in which you clinically have determined they probably have an inflammatory, perhaps autoimmune driven connective tissue disease, then it's appropriate to get an ANA and as a survey to begin with. If it's got high titer, then you have to plunge in further and get subserologies. And there's that whole panoply of subserologies. But that may also lead you to say, well, that's a patient for whom I should get a consultation and let the rheumatology consultant determine which of the subserologies we need, or if all of them. I realize that sometimes that's difficult, and you have a patient who has little or no insurance, or your rheumatology consultant is remote, you may not even be able to get to, and then you are stuck with having to choose and say, well, I got to get this additional information. That's also a good time for you to at that point say, I've got this patient who I suspect has an autoimmune or a inflammatory rheumatic disease. She has a high sed rate. She has CRP must be able, she has certain clinical features suggesting it. And I did the survey and find that she has a high titer positive ANA. That's a good time to ask for a MAVEN rheumatology consultation. And we can then direct you even further as to what either clinical features or what other testing would be particularly useful. And remember, you can ask for MAVEN consultations and develop a dialogue. It doesn't have to be a single shot referral. I hope that answers your question. If not, put in or more specific.
And one more quick question. On slide causes for positive ANA, you had at the bottom age 5 to 15%. What did you mean by age? Did you mean 5 to 15% of
As
the
people,
population?
as people age, the percentage of non-specific, usually low titer positive ANA seems to increase. So maybe 5% in a 30-year-old, and by the time you're up to a 60-year-old, it's 10 or 15%. And yet they are still normal people. There are a lot of purported probable reasons for this, somewhat medication related, somewhat because there are some medications that can give you false positive ANA. And that's a whole list unto itself. But so, yeah, that's the 5 to 15%. If you can get a synovial fluid, what you're interested in, and this is also when you order this and send it off to a laboratory, what does it look like? Clear fluid or or near clear fluid usually has a low cell count. You're interested in whether or not there are a lot of cells suggesting inflammation and whether there are crystals which can be seen under polarized microscopy. And this is the kind of stuff you want to ask. You say, well, I can't draw fluids off of joints. I don't aspirate joints. And most people who are not doing rheumatology or an orthopedic surgery don't do this. However, I would argue that you can, in your clinics, learn very easily how to aspirate large joints such as the knee. It's really quite simple. It's the risk to inducing infection is almost nil under even reasonable aseptic circumstances. This is not a great OR procedure. Cleaning off the joint adequately and using gloves to aspirate a fluid. It is not terribly painful if you can relax the patient, and it's easy to learn to do. So that if you have somebody who comes in who's got a swollen knee, aspirating that fluid will give you a lot of information, and particularly it's useful in diagnosis of gout or other crystal diseases such as pseudogout. So with that kind of background, let's see how some of this might work out. And I've got some sample cases that might help you. 55-year-old Hispanic man comes to your clinic and he's complaining that he has pain and swelling in his left knee. It's very recent in onset. And yeah, he had a similar episode a few years ago with swelling of his big toe. And he thought it was perhaps that he stubbed his toe, whatever it is painful, swollen. And he took some over-the-counter ibuprofen, and it lasted about a week, and it recovered, and he went on his way, and that was fine. This time you find out, no, he didn't have any trauma. He didn't do anything unusual. And the only thing he's got is chronic health issues is hypertension, for which he's on lisinopril. And his work is as a farmhand, and he doesn't recall any exposure to recent cuts or bruises that is introducing infection. Yeah, and yes, he's sexually active, but he's monogamous, so the chance of he sexually transmitted the disease is minimal. And on the exam, you find that, yeah, he's got a little fever, a little chubby, And everything is reasonably normal, except he's got a big swollen, painful knee, and he doesn't want you to move it around. So your differential diagnosis is, I think, pretty apparent. Is this an infected knee, a septic arthritis? Is this gout? Or is this the beginning of another more diffuse chronic connective tissue disease like rheumatoid arthritis? Or is the presentation of something far less frequent like vasculitis? So in terms of your going to the laboratory, blood count may give you a little bit of a clue. Your analysis is chem screening. And his serum uric acid you find is, yes, his creatinine is normal, but his serum uric acid is modestly elevated. That would point you to say, well, the man's got gout. If you could, since it's a big joint like a knee, and you can aspirate it, that synovial analysis is going to be diagnostic. Why will it? You're going to be looking at the questionnaire in the laboratory. You're going to say, what was the color, the clarity of it? What's the cell count and the differential? If it's inflammatory, the cell count's going to be 10, 15, 20, or 30,000. You will ask them for a gram stain and culture, though the yield on this is relatively low, and especially you want them to do a crystal examination by polarized light. And what does that look like? Well, here's what it looks like under polarized light. See those crystals sitting in? If you look very carefully at the slide, you see it's within a cell. And this is what it is with the first order compensated on the upper part of the slide, and without the first order compensation, but polarized light, it's still apparent that there is a needle-like crystal sitting in the cell. This is diagnostic of gout. And by contrast, if you look at the second one and you see these sort of stubby little blue crystals, these are the crystals of calcium pyrophosphate, and that's pseudogout. It can produce an inflammatory arthritis, usually confined to one or two joints. And it's, again, is diagnostic. And sometimes you will see both types of crystals present in the same patient. That leads you then to appropriate therapy, and you can move on. We won't discuss the therapy of gout today. Case 2, a 35-year-old Caucasian woman comes to your clinic, and she has pain in multiple joints, and it's a relatively recent onset, perhaps 8 weeks, 6 weeks. These joints, and she can show you which joints they are painful often at night. They're stiff in the morning, and it takes her a couple of hours to limber them up. That stiffness often returns later in the day. She gets a little relief from a leave that she gets over the counter. And if you ask her specifically, yeah, now it's getting difficult to get dressed, difficult to do her household chores, doing simple things like tying shoes. And if you specifically ask about things like fever, rash, mouth sores, evidence, in other words, of a more diffuse connective tissue disease like lupus or one of the lupus variants, she denies that no, she doesn't have those things. And something that's often overlooked is the involvement of metatarsal phalangeal joints. So you find this out by saying, have you had to change your shoes or your shoe size, or are you having trouble fitting your foot in your shoes, particularly across the toes, because metatarsal phalangeal joints are commonly involved. On your exam, besides your general exam, which looks like it's pretty good, specifically some of her PIP and MCP and wrist joints and her MTP joints, they're a little swollen, they're a little tender, they may or may not be warm. There's a modest limitation of motion. There are no obvious deformities. And your muscle testing is good, except in her hands, because these joints are swollen and tender and painful, and her hand grip goes down. And your initial laboratory shows that she has a normocytic anemia, not severe. Sed rate is elevated, mark of inflammation. Normal urinalysis and chem screen. So in this additional laboratory that you really want to say, aha, I think this patient might have rheumatoid arthritis or is similar related. Now I want to go further with anti-CCP, perhaps a rheumatoid factor, and a chest film to rule out other diseases, disease processes, or even rheumatoid arthritis involvement. Other connective tissue diseases that involve lungs, and to exclude other chest or lung problems, because we're now going to probably start this patient on treatment. So let's go back to the rheumatoid factor positivity. Sure, but look at the other connective tissue diseases in which it can be positive. Sjogren's mixed connective tissue disease, cryoglobulinemia, certainly in lupus. Other connective tissue disease like polyarthritis or dermatomyositis, and even in chronic liver disease. And as I pointed out before, the problem of the normal population. But look at all the other disorders in which rheumatoid factor can be positive. So it's not all that specific, and that's why I said, if you really suspect your patient has rheumatoid arthritis on the basis of clinical examination and your survey tests like blood count and sed rate, then it's appropriate to get anti-CCP. Here's another commonly seen patient. She's 48, she's Caucasian. She comes to your clinic. You've been treating her for a lot of other things like hypertension. She's got type 2 diabetes. And you may not be the treating patient in the or treating provider in the past. You are now seeing her because she has these symptoms which have developed over a period of the last several months. And they're widespread aches, pains, and stiffness, myalgias, a lot of fatigue, non-specific sort of stuff. And if you ask her specific joints, you say, well, do your hand joints swell? She often will say, oh yeah, I have swollen hands, and it's present throughout the day. She's taken some leave, it gives her a little bit of relief. If you ask her about other things like thinning hair, oral lesions, and so forth, no, not really. Rash, not chest pain, no, nausea or vomiting. But if you pursue this, well, yeah, there's some bloating and gas, sort of suggesting that she may have irritable bowel. She has vaginal dryness, but no specific mucous membrane lesions. Sometimes she has diffuse neuralgic type symptoms, but they're transient. It's nothing persistent. And she may get some diffuse headaches. And if you further question her about sleep, yeah, she will now admit she does have some waking in the middle of the night, and in the morning it's hard to get going. She doesn't feel rested, and this whole galaxy of symptoms has caused her to curtail her physical activity. And so she is concerned that she does have some serious inflammatory connective tissue diseases. She's heard about lupus, she's heard about rheumatoid arthritis, and wonders whether she has that. This patient on examination, besides being moderately obese, she has normal vital signs, and her skin is clear, her hair is okay, her mucosa, her thyroid's okay, her heart, her lungs, all this is really normal. They're saying, I haven't found anything. You defer the pelvic exam for the moment. There's some scattered tenderness in some of her muscles, but not specifically, and her muscle power strength is really still quite good. It may fatigue fast, but the general strengthening testing is okay. And she doesn't have any specific joints that are swollen and tender, like the previous patient I presented. And her so-called swelling of joints is rather her subjective rather than objective findings. And in her case, your survey tests, her blood count, her sed rate, her urinalysis, her chemistry are all normal. And her metabolic tests, such as a T4 and her A1C. A1C is borderline, but T4 is okay. And you're going to schedule her for her survey cancer screening because she's now 48. Your question is, do I really need to get a rheumatoid factor, a CCP, an ANA, or an ANA panel, or an ANCA? Do I really need joint films? And the answer is diagnostically, you probably do not, because this patient has a clinical presentation and survey laboratory testing suggesting that she really has fibromyalgia. And you're going to rule out the possibility that these musculoskeletal symptoms are related to a malignancy, which is uncommon and certainly uncommon for that length of time, several months of duration of symptoms. However, you may want to order this to convince the patient that you have really surveyed her carefully and indeed all these tests are normal or negative, and therefore you've zeroed in that she has fibromyalgia, which is very common. Now, by contrast, here's a 30-year-old Native American man who comes in, and he's got some back pain. He works as a stock clerk. He's always thought that the pain's related to his work, his overlifting, etc. And he's taken some ibuprofen and OTC, and they sort of gives him some relief as long as he takes it. When you pursue this a little further, he does have some pain in his back, and it wakes him at night. And if you ask him, well, how's your back in the morning? It's not that, oh, well, I work it out in 10, 15 minutes or a half hour, I'm fine and ready to go. This back pain and stiffness sort of persists. And you find out that he doesn't have any GU problems. He doesn't have, his systemic review is basically normal or negative. There's nothing in his family history that, well, he remembers one older member of the family who was sort of bent over. General exam, normal and okay. no inflammation of eyes, etc. And his peripheral joints seem to be all pretty good. They're fine, with the exception that he's got a little tenderness as you press along his Achilles tendon near the insertion. That's what's often called an enthesopathy. That's the enthesis where the large tendons insert. This can be at the patella, it can be, as commonly at the Achilles. But when you examine his back, because after all, that's where his symptoms are, his on lumbar mobility, it's a little bit limited in all directions. And particularly if you tell him to keep his knees extended, you find that he does not seem to reverse his lumbar lordosis as most young people will do. If you ask me to do that, I'm going to have a poor reversal. But I have degenerative disc disease associated with age. This young man should be able to literally curl his back up. And there are ways you can actually measure this. We call this a Schober's test, but I won't go into the weeds on the details of that right now. But you see that he has limitation of motion, and he may even have some slight tenderness in the paraspinal muscles. Now, when you go to the simple survey lab, he has a normal blood count and urine and chem screening, but his sed rate is elevated, a mark of inflammation. So in your desire, you say, well, gee, I need imaging of his spine. So we'll get lumbosacral spine. Well, if you want to limit your amount of irradiation and limit the costs involved, simply get an AP pelvis film and maybe film of his right ankle where he has that tenderness. And above all, advise your radiologist that you're considering the possibility this man has an ankylosing spondylitis. And while you're waiting for this report back from the radiologist, you can start him on an NSAID and see if he gets a good clinical response. This young man very likely has ankylosing spondylitis or has the presenting spondyloarthritis, which may subsequently be related to either psoriasis or inflammatory bowel disease. What you're looking for in the radiology is evidence of a sacroiliitis. And that's why you want to alert your radiologist to specifically look for that. If there is a suggestion that he has a sacroiliitis and you've got this clinical background, then you're justified in proceeding to get an MRI. And that leads me to the imaging for rheumatic diseases. When do you order and what do you order? Plain films are not going to show you very much in early inflammatory arthritis like rheumatoid disease. Yes, if you have an older patient, those films may show you evidence of osteoarthritis, which may or may not be the cause for their rheumatic complaints. And that's something you have to discern on the basis of our clinical evaluation and the survey tests. If you really got subtle changes of inflammation, you may see some soft tissue swelling. But above all, alert your radiologist why you are ordering these. You can be selective. If you already clinically identified that her hands and feet are sites of clinical inflammation, then films of hands and feet make some sense. If you're suspicious that this is osteoarthritis, like in knees, then get weight-bearing knee films and specifically ask for weight-bearing. That's not routine. If you just order knee films, they're likely to just have them patient lying on the lying on the X-ray table, and that doesn't give you the information that you really want. As I pointed out before, if there's question of spondyloarthritis, a simple AP pelvis will tell you that. Unless you are suspicious of fracture or malignancy or infection, lumbosacral spine films which give you a lot of radiation, are more costly, are really not indicated, and I would say don't do it.
One quick question, Dr. Bernhard.
Yeah,
For I don't know.
ankylosing spondylitis.
Yes, causing back pain, what would be symptoms to look out on HPI to tell you this is not a regular muscular strain?
Oh, this is usually younger people, but not always. And sometimes we say, well, this is a male disease. We have now finding out that's not necessarily true. And it's pain at night. It is pain persisting in the morning through the day. It's pain on ordinary activity, not necessarily related to overuse or heavy lifting, and is associated with limited mobility of the lumbar spine, usually nothing peripheral, and sometimes some spasm of the muscles, and an elevated sedimentation rate. And as I pointed out, if it's been persistent for any period of time, you may see some evidence radiographically on a simple AP pelvis film. It's that combination that suggests that this is an inflammatory process in contrast to not. If you're looking for it in women, particularly multiparous women, you have to do, the radiologist needs to know that you're looking for spondylitis, an inflammatory disease, because multiparous women often have what's called osteitis condensans ilii, which is radiographic changes on both sides of the sacroiliac joint, but an intact, normal sacroiliac joint. It's subtle, but the radiologist can discriminate this and can help you with this, but only if you give them the clue. I hope that answers the question. So the MRI is rarely useful as an initial evaluation, so you can be selective and use it after you've got the plain films. And there's now some evidence that you don't want to overuse a CT scan, because a CT scan will give you useful soft tissue information, but about your tissues and disease, but it's quite different. And this is really more useful for spine than it is for peripheral joints. Obviously, a CT scan, if you're concerned with retroperitoneal involvement or some organ issues abdominally or in the chest, but that's getting on beyond the survey discussion. So with that background, I'm open to discussion, questions, or criticisms.
While we wait for questions, I'm going to put some reminders in the chat.
We've got about 10 minutes, I think, left in the hour. Have I answered the questions that have been submitted so far?
Yes, you did.
Okay. And I hope you can, from this, go forward using these tests more directly, specifically, and judiciously. because I know this is a cost issue. It's an availability issue. And if you do combine the clinical features with the survey tests, you set things up properly to get the most out of a rheumatology consultation, or directing you sometimes to a neurologic consultation, because or to other subspecialties.
Okay, we do have one question. When would
Yes.
when would you get a CBC for back pain?
When would I get when would I get I'm sorry,
When would you get a CBC for back pain?
a CBC, a blood count for vaccines?
For back pain? It said, when would you get a CBC for back pain?
I'm not sure what we're asking. A CBC is a blood count for a vaccine.
Okay.
No,
Yep,
that
that's
doesn't.
Lena, did you want me to unmute you? So if you wanted to ask him?
Yeah,
Okay, I'm gonna try to unmute her and see if she wants to ask.
yeah.
Okay, well, before I do that, I also have any quick antidotes for juvenile presentation and workup.
Pardon me, try that again.
Any quick antidotes for juvenile presentation and workup?
Ah, if you got if you have a younger person, and I'm really talking about people less than 18, who come in with musculoskeletal symptoms, you do the same thing you would with the adult, i.e., find out more specifically what the symptoms are, where it's located, how it's interfering with their function, whether there are any other features like eye inflammation, skin rashes, functional problems. And on the examination, again, look for specific joints. And what would you do in the laboratory and the survey? Same thing, blood count, sedimentation rate, make sure that that they're metabolically okay, i.e. that their that they are not diabetic, that their thyroid function is normal, the renal function is normal. Same things you would do with the adult, but in addition, in your survey tests, you do the same thing, a SED rate, perhaps a CCP, or maybe a rheumatoid factor or both, and an ANA as a screener. If the ANA comes back reasonably elevated and you have evidence of inflammatory arthritis, then you're dealing with someone who has a juvenile onset of one of the rheumatic diseases, and that needs to be pursued still further. If your rheumatology consultant has any experience with juveniles, that's great. If you don't have that available to you, get to one of us in the MAVEN Project, and we can give you further direction, etc. But these are issues, and kids who have can present in a couple of different ways. Early ankylosing spondylitis in young boys sometimes presents as a peripheral single or double joint inflammatory arthritis, and subsequently they will develop back pain, etc. There is a polyarthritis which occurs in really young kids, which is called juvenile idiopathic arthritis. And that should really be seen by a pediatric rheumatologist. And I know that they're hard to come by. Those who are a little older, who gets just a few peripheral joints involved, often have eye inflammation These are so-called, this is idiopathic juvenile arthritis, but it's of a different ilk. It occurs in usually teenage girls. It should be treated with an anti-inflammatory, but again, this is best seen by a pediatric rheumatologist if available, if not, certainly an adult rheumatologist.
Okay, another question. How do you convince a patient with an ANA 1-40 without evidence of a rheumatological condition that they do not need a room consult?
If you've gone through that far, you can say, well, look, if you're concerned about this, I can get you a panoply of other tests. And yes, that's the point at which you say, okay, it's worth getting the second round, if you will, of antinuclear antibody testing, which laboratories will do as a big panel. But you can point out to them that this does occur in a positive ANA like that does occur in normal people, and it may be associated with their recent viral infection. It can be associated with birth control pills. It does not necessarily mean they have a significant rheumatic disease, especially if the rest of her laboratory testing and examination is absolutely normal. That's the point at which you sometimes have to go and get the additional testing to convince the patient that no, they do not have a serious, deforming, life-threatening, progressive, inflammatory autoimmune disease. And if that fails, then sometimes you have to refer the patient on. But that's the kind of patient that rheumatologists are going to say, why is this patient here? I have nothing further to offer you, etc. And they're going to have to probably wait a long time to get in. One of the advantages of doing good clinical evaluation and having some evidence of inflammatory disease, which you can gather together, and then asking for your rheumatology consultation is you can present that kind of data to the rheumatologist, and that rheumatologist can say, okay, this is a patient we should see relatively soon versus we can see them next Shrove Tuesday.
Another question, what about getting 25 OH vitamin D? Low levels can cause pain, right?
That's a very debatable discussion as to whether getting 125 hydroxy vitamin D levels that are low, does that really have a relationship to rheumatic symptoms? There are those who would tell you, yes, it does, and those of us who would say we're very questionable about that. I happen to be in the camp that says, show me the evidence that it really is so. If you're concerned about it, get the test. If it's low, supplement with vitamin D. It's harmless. It doesn't cost much. And you may easily find out that the symptoms do not go away, even though their 125 hydroxy D level rises into the normal range.
Hey, and I think that's all for the questions. And we're at 1:30. So thank you so much,
Okay.
Dr. Bernhard, and thank you so much for everyone that
Oops,
attended.
there's one who raised her hand.
Oh,
Lena
maybe,
Batista,
yeah,
what
I
do you
can
want?
unmute you. Hold on. Let me find her name. Trying to get to you, Lena. There she is. Okay, you're unmuted.
Ah, yes. Thank you so much. I do telemedicine So I don't have the benefit of an exam. So I was asking, when should I be alerted to get a CBC? Because you mentioned CBC for ankylosing spondylitis. So when should I start to get labs on a patient with back pain?
Oh, I think you've got somebody with a back pain and you're suspicious that they might have inflammatory spondylitis. Get your blood count, get your sed rate. If you want to convince the patient and yourself that they don't, that this, if this has been chronic over a period of weeks, months, or longer, then the single AP pelvis film might be useful.
Thank you.
Yeah. I mean, you're not talking about expending a lot of money, time, and energy, and you're not really exposing them very much to radiation. If you put that together with your clinical exam and that history, you'd be in pretty good shape.
Great. Thanks for your talk.
Good.
Okay. Well, I think
Good.
we're all set. Thank you so much. That was a great presentation, and thank you to everybody who joined us today. Hope everyone has a
Well, I
good
hope
rest of your day.
everybody got something out of it. That's what it's all about.
Yep. Sure they
Thank you.
definitely did. Bye. Have a great day, everyone.